Hello and welcome. You are listening to the podcast that asks the question too many people forget. What about rural health? I am your host, Chinasa Imo. Together, we are uncovering the stories, challenges, and innovations shaping healthcare in overlooked communities. Today's episode is titled Innovating Under Pressure: How Rural Hospitals and Primary Care Can Survive Funding Cuts. When we talk about rural health financing, it is easy to get stuck in the numbers and infrastructures, such as scarcity of life saving equipment and medicines, shrinking budgets, workforce shortage, hospital closures, and now the real possibility of deeper Medicaid cuts, which may lead many clinics and hospitals in already resource shrinking communities to pack up shops. But what we sometimes fail to understand is that behind those numbers are real people, real communities. In the US, nearly 66 million people live in rural America. A quarter of all veterans and millions of children also live there. And yet, more than half of rural hospitals are operating in the red, and some of them are already closing. At the same time, we are staring down on potential Medicaid cuts for rural communities and the people who receive healthcare services in these settings. Medicaid is not just a side program, it is their lifeline. So the question is not just how much money is being cut. I am flipping the question to ask: how do rural hospital and primary care systems, especially safety net providers, survive? How can they even innovate when funding is shrinking so that they can continue providing quality health care to the American population? And I will add, without sacrificing quality in care, dignity, or outcome. And that is where my guests come in today. But before I introduce her, let's take a quick break. If you are enjoying this conversation, don't forget to subscribe to What About Rural Health on all streaming platforms. We are on Spotify, Amazon Music, Apple Podcasts, Listen Now, and so on. And yes, we are on YouTube too. Your support means a lot to us. So please leave us a comment, share, and most importantly, drop us a review. It helps others discover these important conversations. All right, back to the episode. You are still listening to What About Rural Health with Chinasa Imo. Without much ado, let us introduce you to my guests. Joining me today in the studio is LuAnn Kimker. LuAnn is a registered nurse by training, a system thinker by practice, and currently serves as the Senior Vice President of Clinical Innovation at Azara Healthcare, where she leads efforts to advance data-driven strategies that strengthen primary care, population health, and safety net programs. LuAnn brings extensive experience in managing primary care and specialty practice operations, quality improvement initiatives, and the development of sustainable patient-centered medical home program. Through her work, she partnered closely with primary care networks and community health center leaders to design and implement practical data strategies that integrate clinical, payer, and social determinants of health data. In a rapidly evolving healthcare financing landscape, LuAnn's work reflects a strong commitment to the mission of healthcare safety net, helping providers deliver better care to lower costs at lower cost while navigating significant financial and operational pressures. I am grateful to have you here for this conversation, LuAnn. Welcome to What About Rural Health?
Oh, thank you, Chinasa. I am really excited to be here today. I think this is a very timely topic in rural health. And, sometimes rural health is not what is first on the agenda. And I think this now is an opportunity for it to get a little limelight and see how we take advantage of that.
I agree absolutely. And what I it's like I failed to mention that in this dispensation, I don't want to say in this Trump administration where healthcare has become like a more population issues that is driven to the background. This is definitely a time that we should amplify conversations that recenter this back into the priority conversation. So thank you very much for mentioning that. So, to our listeners, as you listen to this conversation, I want you to think about your own community. When funding gets tight, what happened to care where you live? Who ends up absorbing the cost financially, emotionally, and operationally? And when decisions are being made about who to fund, who to cut, or what to optimize, whose needs are they protecting and whose voice are missing in the table? I think this is a whole lot of question for us all to grapple with while we make decisions on how we engage with policy stakeholders, community leaders, and decision makers. All right, welcome back. So, LuAnn, let's get into the weeds of the conversation. You work with clinics and health centers across country, many of them serving rural communities, and they are under-resourced. So when you look across these systems right now, what is the most acute pressure that you are observing?
It's interesting when we think about healthcare, we generally think and like to think that we're moving forward and making advances. And I think generally we have been. We want to improve the health and the lives of everyone.
Yes.
But this past year has been a little volatile and it's created challenges. And so those particular pressures that we've seen have been uncertainty, and knowing where their funding is coming from. And that's making it difficult for organizations to know what they can do and if they'll have the funding to do it. And as we've seen in the past year, it sometimes changed from one week to the next week as to what they had funding for. Patients are sicker. They've waited longer to get care. I think we see this a lot in rural health also, where access may be more difficult, or they can't afford preventive care. When they're sick, those same people are the workforce. So in rural health, when there is a larger, and larger is relative in critical access hospitals, that community, they're the people working at that hospital. And though there are shortages. Infrastructure to allow data sharing and communication. And then, of course, lastly, I would say are the regulatory pressures. There are different programs, and if you want to be paid, there are oftentimes regulatory criteria that you have to be made to maximize your revenue. And that's hard when you don't have the right systems in place.
Wow. That's enormous. And yeah, the pressure that it seems like the pressure is all around the facilities are facing, the citizens are facing, and then we often ignore the fact that we are talking about the health and well-being of the workforce that runs the entire economy. Like if there are no healthy workforce, how do we generate resources to run government? So I'm gonna ask you a question because we might be using this word, oh, hospitals are operating in the red, and we might not really unpack what that means in real essence. And we hear statistics all of the time saying over 53% of rural hospitals are operating in the red, right? Help us
Mhm.
understand what operating in the red actually looks like in the day-to-day inside facility where these medical service providers and other allied care service providers are struggling to provide care. But I want you to be more emphatic on the rural hospitals and clinics.
Yeah, operating in the red, their budgets and their bottom line are impacted significantly by minor changes.
Mm.
If you think about it, your patients, like if you're living paycheck to paycheck, a hospital that's living paycheck to paycheck is worried about covering its payroll. And so, and a lot of the safety net, this is true in health centers, but also in the critical access hospitals. Sometimes there is federal funding that they have and grant funding. And so when those things change, that may change what they're able to provide to their patients on a regular basis. Um, a lot of organizations um, feel then like they're living in fear or uncertainty, so they are less likely to think about new programs that they can do. And they'll think about cuts. And usually if they think about cuts, those cuts are to their people first, because they'll try to do more with less, which just puts an additional strain on it. And then you'll start to see the programs that will drop because of that.
Thank you. Thank you for your response. And I want us to drive this home and closely to Medicaid, because in rural communities, Medicaid is the backbone of care, especially for people who depend on, like, old people, um, children, adolescents, and women within reproductive age who depends so much on Medicaid for their services, right, as a safety net. We have continued to face this loom. There's always been this back and forth conversation of, should we cut Medicare? Do we leave Medicaid? When we even bring the Obamacare into the conversation, it's a whole lot of political prioritization within that discourse. And this shape decision making. So when money is tight like this, what do you think get cut first? I know you mentioned in your previous response to me that people get cut, but, like, let's perspect that. Is it like staff, or people who deliver the self preventative care, or is it like, innovations that now have more people are becoming to be more technology driven and less human centered? What exactly is at stake within these rural community centers?
It's a great question, and I think I'll start with sort of the cuts to Medicaid and what's on the immediate horizon, right? And that's really impacting coverage and the
Mm,
number of people who may be covered or will have to jump through different hoops to
mm,
maintain their coverage. During COVID, a lot of those guides and regulations were dropped to make sure that people had care and people weren't getting out to get care. So now that things are back to normal, the changes that are being made to Medicaid will make it more difficult for people to be eligible, and or that they will have to meet certain criteria to maintain their Medicare coverage. And that population often has less resources, less ability to communicate, either through technology or because of their homelessness, or because they move locations a little bit more frequently, or they're working and they're just not, it's hard for them to do that. A lot of paperwork or work requirements. And so health centers, what that will mean for them is that if they had, and I'll use very low numbers, right? If they had 100 covered lives through Medicaid, it could mean that 50% of those may no longer be covered.
mm,
If they're not covered, then they're not coming in for services, or they're coming in and those services are not covered with revenue, which
mm,
means that my revenue as an organization is going to go down. excuse me,
Yeah.
we've had um we've started to have conversations with um states and networks where they're looking at this now. And one of our CEOs has said, the first thing that people want to do is cut administrative staff, cut the people that help get patients on Medicaid or make sure they fill out the right forms, et cetera. And he's like, we don't want to do that,
Yeah.
because if we do that, we're going to cut our revenues automatically. This is a time where we're going to need to stay staffed in that area, and find creative ways to educate patients, not just sign them up, but educate them around what they need to be able to do and to be able to track what they as an organization are doing to support those efforts and keep those patients covered and getting the care that they need.
Mm. Thank you so much for that response. And when you were talking, I was just thinking that leaders has a lot to grapple with in this decision-making space. That's a lot,
Yeah.
you know. And I'm just wondering, like, I know you mentioned the CEO you have conversation with, but like broadly within these day-to-day managers of this primary care and um, federally qualified health centers where they receive funds to provide these services from the federal government now are being faced with all sorts of conditionalities. What does this moment feel like for these leaders? Like, this is not more about, okay, this is the practical thing to do, but like, how does that show up? Is it like fear, frustration, or just a mix of a whole lot of feelings right now?
It's definitely a mix of a whole lot of feelings. um it's the fear and uncertainty, right? But I think for those organizations that are going to be successful, and let me back up by saying this type of fear is not new to these organizations.
Okay.
um they've had to fight, since the beginning of health centers, back in the 50s. They've fought for the underserved areas and people and done that really well. So that still doesn't mean that it isn't painful, um, or frustrating. Um, but what we see sometimes is a lot of them just sort of getting mad,
Mm,
but being able to take that and be really creative about how they can provide services, because they over time have built up some really good programs and they're dedicated to keeping those in place. um, and I think the challenge is, what kind of supports and things do they need to make them successful and be able to do that with as little, I'm going to say little resource as possible, but that's what it looks like sometimes.
yeah, I like your response. It just seems like, oh, okay, this is old problem with new face. And
Yeah.
and we're gonna figure out because we do this job on the ground and we don't want to pack up shop. So we're gonna figure a way to continue to alleviate all of these problems and be able to deliver care. And that is, to me, that's refreshing, but also in some ways comforting for those who come to receive services. But however, I still want to know, like, for the families and the patients who go to get these services, I mean, they don't sit in this room where these leaders are permutating all of these things to come up with innovative and creative way to continue existing. How do you think that they show up in their own everyday lives, those who receive these services?
Say a piece of that again, Shanasa.
I'm just trying to figure out, like, I'm moving from the providers to the beneficiaries, like the families, the patients who come to receive care, what all of these decisions make them feel about the system?
Well, they don't trust it sometimes. They're not, they often they have the potential to get hit with bills, or they may be afraid to have a service because they're going to get billed for it. They may not have that procedure or that test done because it won't be covered, even though that's what we might consider standardized care. So I think that's hard for them. Access, when we talk about rural health, I think access is a big piece of that.
Yeah.
And so I don't know, I've experienced it myself, and I have the means and the ability to get to appointments really easy, and a job that allows me that flexibility to do that when I need to. Sometimes in the rural health population or the underserved, that's not the case. And so, we make it harder for them to be able to get care. And when it is limited, what we can do as an organization to provide the most flexibility for them to be able to get in is better, and not make them have to come in unnecessarily. So in rural health, that means being able to share information between different organizations, and make sure that if we've done testing in one place, we're not repeating it in another that's going to cost them or not be covered. I mean, that's just good care and principles to begin with. But I think we sometimes forget about that because this is what's easiest for me to do my job. So I think we need to always be thinking of that, even when the organizations are stressed and finding it difficult to provide that care.
Thank you. We are going to take another short break, but before we go, I just want to reflect back all that we have discussed so far for our audience. What I'm hearing you say is that these budget conversations, they are not abstract, Facilities are really trying to survive so that services would not be disrupted. But we need to set the record straight here that cuts do not just reduce access to care, they destabilize the entire health system that rural communities rely on. If you don't take anything away from this conversation, please take this back, that it destabilizes the whole entire system. It could be innovative, but it could pose strenuous challenges for those who receive specialty care in rural community. So let's take a break. Do you have a rural health stories that need to be heard? Whether you are a health worker, patient, policymaker, or advocate, we want to hear from you. Share your story on our website at www.whataboutruralhealth.com/stories and help us amplify the realities behind the number. Someone from our team will contact you with details on how to get your story published on our newsletters, website, and other media platforms. Welcome back. You are still listening to What About Rural Health with Chinasa. So, LuAnn, I want us to shift this conversation to data, and I know that is mostly the thing that you support these hospitals and facilities with. But we are going to discuss this carefully because many rural providers, data and technology can feel like another burden, another luxury that we cannot afford. But in moments like this, when data is central to understanding where and how to prioritize care, yet funding is shrinking. From your perspective, how does the use of data become important, not less, for rural health financing sustainability?
Having the data infrastructure is what's going to help them to be successful. it's unfortunate that where we are today, that many rural health facilities don't have that infrastructure already. And I think if you think about just sort of the timeline and how health care organizations have evolved, and I go back a little while to, moving into the 2000s, right, where very few doctors' offices were even on electronic health records. Okay, so it's taken us 26 years to move from a very small percentage of providers using electronic health records to the majority of providers using electronic health records. Electronic health records provided information really started around billing and documentation. And in today's world, if we're going to provide care to populations and not just the patient who walked through my door, we need to be able to look at data for a group of patients, understand for that group of patients what their access is like, what their conditions they have and how well controlled they are, how well of a job are we doing to support them in the care of their chronic conditions. And also then what are the other factors like social determinants or drivers of health that come into play with their ability to get their care. And then think about that, not just at my organization, but how do I share that within a network? Other critical access hospitals in a geographic area or health centers or behavioral health centers so that we can provide comprehensive person-centered care for the population.
Thank you for your response. And I want you to match this with an example of how data is helping these leaders make better decisions under financial pressure. Because I like my audience to have a clear picture painted for them as they listen through. Are there times when these leaders are forced to make decisions without good data? Are there ways that fragmented data give them financial pressure or make it worse?
Yes. Yes is the obvious answer to that. When we think about it's hard to make decisions if you don't understand what your population looks like. And so from an organizational level, being able to have data that helps you understand, for instance, if I'm caring for patients with diabetes, what's the average number of visits that a patient with diabetes has, right? And so do I need more providers? Do I need more care team, ancillary staff, CHWs, community health workers, nurses that can help provide that care? Being able to have access to data like that can make a day-to-day decision and know where my gaps are from a population perspective. I also then, there are organizations where we've gone to and they're like, oh no, we provide really good care. And then you actually look at the data and the quality measures, the clinical quality measures, and you can see where maybe you're not doing as well as you thought you were.
Yeah.
And there's a couple reasons for that. One, it could be that it's not documented right and you're not capturing it. Or there's something that's getting in the way, whether that has to do with transportation. Are those patients able to get in? Are they homeless? When you have collective data and you're able to gather that information and then be able to use it, those are the kind of insights that you can get that will drive actions that you want to take. One of the critical access systems that we work with implemented a data platform across multiple critical access hospitals as they were part of a funded program, but it allowed them to be able to report similarly on the same data and understand where their gaps were, and then be able to advocate at the community level or with your Department of Health for other funding to support the care that you're providing.
Thank you for that response. And I want us to bring this home because a lot of safety net providers, they will hear tech partners and think another system, another login, another cost. And you just mentioned it, like some of these care providers, it's not like they're not providing quality care, but probably they don't have the right system that is capturing it, right? And that is where Azara Health comes in. And I see that the organization work with a large number of federally qualified health centers,
Mhm.
primary care networks, and safety net providers. Explain a little bit for the purpose of my listener who may not know the difference, between all of these things. What makes safety nets and rural providers different from like a large health systems that we might see in very big urban environment?
A couple of things. One is, well, clearly those larger systems usually have access to more dollars, right? And when you're doing things on scale, it can be at least initially less expensive to do that. They also have teams of analysts and IT people to do that. When you're in the rural setting, you have one person sometimes, or a much smaller team that's wearing multiple hats, from finance to quality to operations, and running all the reports for their regulatory reporting. Our philosophy from a population health and analytics tool is, how do we make the things that need to be simple?
Yeah.
From a world where we used to do chart reviews and only a subset of the population, to being able to look at the whole population and how they're doing, and to be able to do that by the push of a couple buttons, not needing analysts to dig into that data and find out that work. And so that's what a larger system has access to all the time. And people driving those reports. Our goal in working with a rural system, a federally qualified health center, is again to make it easy to do their core work and get the information that they need with as little trouble as possible.
Mm.
But the other thing that I would add is that one piece of data can be used differently by 3 different people. The operations manager may use it to understand, are we getting patients in, and are we maximizing our resources and filling our schedules and doing it at a quality level, right? The provider wants to know, the patient standing in front of me, what information do I need to take care of them? What's missing? What preventive care haven't they done? What referrals have been made for them? And they need to be able to see it quickly. And then there may be a population healthcare team or a quality team that's doing state or federal level reporting, and they need to be able to get access to that data in a different way. And so with the right data platform, you can start to serve up the right data to the right people in a more efficient manner, so that they get what they're actually in need of.
I like your response. And I'm going to bring it down to we are in Azara Health Services, and the support that you provide to um, primary care networks. And I just wanted to ask you, as a tech partner, what does trusted tech partner means in these rural health settings where margins are thin and the stakes are high, but you are there
Yeah.
supporting them, unlike these big health systems where they have all the experts that they need running their numbers for them?
Um, I think that, you know, for Azara in particular, um, we were built for federally qualified health centers. That's where we started. The majority of our business is in safety net, hospitals, critical access, and federally qualified health centers. So it's a, you know, it's a mission that we hold very close to our heart in terms of being able to understand what their needs are. Um, and so as we develop functionality and tools, it's to think about how do we make it easier for them to do their work and also be able to provide them with some training around how to best use those tools
Hmm.
in what they're doing, and maximizing that with their EHR. Um, we one thing we haven't talked about, Shanasa, is that no matter where you're providing care, um, there's a ton of data out there.
That's true.
And there's clinical data, there is data from what might be your health information exchange, but people who are admitted and discharged to the hospital. There's data from Medicaid, Medicare, Blue Cross, whatever commercial insurance plan that you have. And all of those different organizations are throwing data, I say throwing loosely, at the leadership and telling them, we need this, we need that, take care of this population of patients, take care of this populations of patients. It's outside of their EHR. And so a data platform tool actually allows you to bring those pieces of data together and then find out where are the true care gaps that we have, or who are the patients that are at greatest risk or most likely to end up hospitalized, and how can we then create programs that support them and try to reduce the costs associated with admissions, or make sure that we follow up in a timely manner. And so we, as a population health platform, we're trying to pull that stuff together to make it more usable and serve up insights that can help them in their decision making. I have a good example that I can share, and this has to do with automation and outreach. And so if when we can identify patients who, let's say, are missing their cancer screening, colorectal cancer screening or a mammogram, we can identify that automatically and put them in a campaign that sends out messages to call them, not to call them, but to text them, tell them they're overdue for services, call us, click this link to book an appointment, any of those options. Those are things that historically, and in some cases, are still done by people making phone calls. But if I'm short staffed, or if someone calls in sick and I need to be able to take care of the patient standing in front of me, that person gets pulled. And so that work never happens. And yet it's really important to feed the work for tomorrow and the next day, and make sure that population is taken care of. So that becomes a return on investment in terms of, where do I use that resource, a human resource? Where do I need to use a human resource? Where can I use automation to be able to support the care that we're providing and be more efficient?
Good. So what I'm hearing you, in a sense that you had explained here is that you come in and blend all this clinical data, payer information and data.
Mm-hmm.
And also, in some way, I'm hearing you with the example that you've given social determinants as well. All of these things, you put them together, and I'm just imagining, and we have established that fact already, that most of these places are already overwhelmed. They're
Mm.
overwhelmed with data, they're overwhelmed with service provision, then adding financial costs, meaning they have short staff as well, right? Um, Do you think that over the years, not do you think, have you seen that these tools are making life easier for these care providers who now rely on these automated, comprehensive data that is put into one place, and you provide like technical oversight and training to them? Does it, I mean, it's an obvious question, but sometimes data could also be encumbrance and overwhelming as well. But do you see
Yes.
that it shifts them to, having a more easier process to operate?
Um, yes. And that that takes a couple of things. One is leadership being engaged, involved, guiding the work that's being done, not just for providing care, but the administrative pieces around it. So, thinking about the goals of the organization, nobody likes to be schizophrenic in terms of the things that they're trying to accomplish.
Yeah.
And so, being very specific about what we're focused on, and it doesn't have to be perfect, right? Like there, and we see this sometimes in rural health, other settings, like I can't do this until all of these things are in place. Sometimes, if you're going to be able to innovate, which is I know you've asked about, is that you need to be willing to use the data that you have, make a change, look at the data again, and adjust. You can easily see in the data where when you've implemented something like automated outreach, the impact of that, how many appointments did that result in? And how many care gaps did that close? And how do you bring that back and share that with the team to show that success?
Thanks for that response. So I want to bring this one both to you, but specifically for primary care delivery. You've spent a chunk of time, of your career life in primary care and population health. And this is me poking or crawling into your brain to understand, why do you believe primary care is the smartest investment point for rural health stability?
When I've done different projects and different engagements, some of my early work started with the Institute for Healthcare Improvement and driving change in practices. Primary care, we have to work with our patients to make them a part of their care and understand, make sure they know what's important for them being healthy. Most of healthcare and management of chronic disease happens outside of the primary care office, but
Mhm.
it's certainly not happening at the specialist or the surgeon's office or when you're in the hospital, right? Like that's just not the place. Primary care needs and is a place where you can have support for your social, clinical, chronic conditions and behavioral health needs, and start to put that in place, because it all trickles down, right? Or I should say snowballs. If you're not taking care of those things early and getting the care that you need, it's going to show up from the 11-year-old who's struggling in school and we're not able to get them the right care. That's going to show up again when they're 15, 18, 24. And then we're in a pathway and a cycle that is much harder to break.
Good. So,
And to me, it's a team, right?
yeah,
So we talk a lot about providers, and that is a really important piece of it. But over the years, seeing how now funding and supports a bigger than just the provider. I mean, that's the key of value-based care, is thinking about the team that's going to support that population of patients.
Thank you. We'll take a quick break, and then when we come, we transition to talk about innovation more closely. Do you want to help drive rural health forward? We are looking for passionate volunteers to support our work, from research to storytelling to outreach. If you believe every community deserves care, join us. Visit the link in our bio or show notes to sign up. Welcome back. So, LuAnn, we are back to this conversation is how are rural health care providers innovating? Whether innovating in a very challenging environment or innovating to meet the needs of their clients. All of these things has to do with um, budgets. So within these shrinking budget conversations that we've been having, especially beginning from early this year around health, and we know innovation is risky, like coming up to say, I want to do this, and it's the first time you are trying it out. What does responsible innovation look like in this moment for rural hospitals?
So part of it I mentioned already, and that is being willing to try something new.
Mhm.
And I think as you're doing that, thinking about what is the return on investment for doing that? What is the outcome that I'm looking for? And did I get that? Um, and to do that, you have to be pretty specific. You have to outline what that program looks like and what you're going to change. I think also um, it it means looking at different technologies. So while data platform is one important piece of that, what it does is it allows you to share information. So we've worked with um, health centers and behavioral health centers. So like part of what we have to remember is it's not just the health center, it's not just the critical access hospital, it's the other services out in the community, and how do we connect those? So when you have a data platform in place, you're actually able to think about sharing and viewing that data so that I know what the behavioral health, what mental health or behavioral health services are being provided and how they impact what I'm doing for primary care. And they know that same thing. And so sharing information is innovation because normally they can't get that. And so sometimes it has to start really small. Other types of things that we've seen is programs for housing and or food insecurity, where you might get your prescription for food, and that works for the local community food bank. But you're seeing organizations that are partnering together and sharing data about those results so that they can get services easier.
Yeah, that's good. But is there something that you feel like some of the leaders are still trying in a wrong way, using innovation and getting like an alternative outcomes? Like
And
if there's
getting what
an
outcomes?
example, like if there's an example of where leaders are still getting it wrong with innovation.
um there's plenty of places where we're getting it wrong, right? And I'll counter that with plenty of people that are doing it right.
Mhm.
um and I think um the wrong way to think about it is that this is impossible and I can't do it. We need to break it down. We need to use data, find what it is you're trying to address, right? And it may take time, but you've got as a leader be consistent with that messaging. Um that's where we see the most change happening, is in a leader who um creates a team and environment where it's okay to fail. you just need to talk about what that failure is and be willing to make changes. You also have to take a little bit of time and effort to understand what's going on, and make sure you're not missing something in that process. And we've seen the data helps people support the changes that they're trying to make, because they're able to say, we had care management. Pharmacy is a great example. If you can put a pharmacist or some sort of clinical pharmacist in your primary care setting to help with medication adherence and increasing medications. We've done some work with the AMA in terms of their MAP programs for hypertension and showing that control. We've had organizations where they thought they were doing repeat blood pressures on patients if it was high. We've got measures that show them this is where you didn't, and or you took it again and now it's lower. So if you take the time to do that, you will perform better. The patient will get the right medications. You will perform better on your quality metrics and things that you have to report at the state level, which will then result in you have a higher ranking because you're seen as a quality organization, and the funding or contracts from your payers will result in more payments.
So what I'm hearing from you is that both the funders and the decision makers and the service providers at this moment needs to, innovation means more like sharing data and checking in with every service point to make sure that we are cutting duplications, but also we are cross-learning. We are opening ourselves internally to being able to learn and pivot from what is working or what is not working. I mean, pivot from what is not working, but scale what is working. But most importantly, work in a more concerted way than fragmented way, so that we don't continue to repeat services that are not needed, or that does not produce any additional layer of outcome.
Right.
So what I would ask you now is, if you are sitting in front of, whether it's a rural CEO or a local policymaker, what would be the first thing that you would tell them to focus, bearing in mind that we are in this crunching moment where everyone is innovating to keep the health system going?
Which leader am I talking to?
Any leader. I'm just I'm just being abstract. Like if you're sitting in front of, say, a
Yeah.
CEO of a rural health clinic or hospital, or you're sitting in front of a local policymaker,
Yeah.
yeah, what would be the first thing that you tell them at this point in time? Guy, let's be practical. This is what you need to focus in doing.
Right. So I'll do two pieces from a policymaker. Sometimes we talk about simplifying the administrative burden. I don't know that we always do that. So thinking about programs and having similarities across the programs, because if I as a health center or organization leader have 10 different programs that I have to manage, it's really hard to be effective, especially when they have limited resources and they're building up the infrastructure. Or from a policy perspective or an outside partner, you need to help them build up that infrastructure to be able to do that reporting easier. For a leader, it would be to create your data infrastructure and data governance, and who's going to use it, and make them use it. Every meeting should talk about what the data and the success or where you need to change is. And when they have data, they have power. And so they have the power to talk to the Department of Health, the policymaker, the person at their technology vendor, right? To say, we have these problems, here's the data behind it, and this is why we need to do this. And they can, in value-based care, where we're doing a lot with rosters and patients are assigned to certain organizations to get their care, understanding, like, we give organizations the ability to be able to see when patients are assigned to them, but they've never been seen at that organization. They're going someplace else. How do you work that into what you're doing, right? And how do you focus then on the right patients and the right members to make sure they get the right care? So you're making the best use of your time. So focus on what you want to do and the right tools to be able to do it.
I love how you say that data is power.
Mm.
And I have been imagining, like in my own previous work where I work on maternal and newborn is a whole
Mm.
lot, RMNCAH, but focus on maternal and perinatal death. And what we're doing is establish this structure where health facilities begin to use data to determine why did the woman die, why did neonates die, why did we have complication in birth delivery, and all of that, and just seeing the enormous shift in resource prioritization, but also in upskilling of the service provider by being intentional in incorporating data in
Mm.
their decision from get-go and using that to review themselves, review the operational procedures, and figure out the things within their service delivery spectrum that is making it either difficult or easy for them to deliver care. It changed a whole lot
Yeah.
of, the narrative on how data shaped the level of care that they were delivering, but also the quality that they began to deliver. So I agree with you that data is absolutely important in every level of service delivery, but most importantly in rural healthcare, where sometimes
Right.
the patients themselves have limited knowledge or are not that much learned in the health systems and may not be able to describe in clear terms what they feel, then that is where data guides you more as a care provider. So as we wrap up, LuAnn, and thank you so much for all that you have contributed to this conversation. But as we wrap up, when you think about the future, because I like to close on a good note, we can talk about all of the problems of the world and the one that will emanate tomorrow. There is still that glimmer of hope that we have, and which is why we buff up and show up every day to do the work we know best.
Yeah.
So when you think about the future of rural health, what gives you hope, even in moments like this?
I think that we are at a we at a real turning point where time and attention is being given to rural health, and I think that's really good. We didn't talk a lot about remote monitoring and telehealth, but 10 years ago, I don't, we were using it just a little bit. COVID pushed us a little bit, and then we moved backwards, right? Because the payment model
Mm.
didn't change. So I have hope in things that COVID caused, in all the bad parts of COVID, that has caused us to look at some things differently in terms of how they should be integrated into a part of the care that better supports our patients versus just is difficult for me as a provider or an organization. And I think some technology partners have stepped up to make those pieces easier and more integrated. So there's a lot of innovation that can still happen. And we will learn what we learn even in doing the rural health piece of it. And I'm excited to see what the rural health transformation grant, how that gets rolled out and the opportunities that it
I'm also
creates
excited about that.
across the country. Like
Yeah.
rarely has money been distributed across the country with that specific focus. So we'll see how that goes, but that's exciting.
LuAnn, thank you so much for bringing both your honesty and clarity to this conversation and for reminding us that innovation in rural health is really not about doing more. Because sometimes we think innovation is about bringing this, abstract, gigantic new idea, but it's about what matters. How do we incorporate technology? How do we use the data that we're already generating, but now be more conscious about putting them together in ways that they become indicative of how we tailor services, specifically to the demographics that we care about. So thank you very much for that.
Thank you.
To everyone listening, thank you for joining us on today's episode of What About Rural Health? If today's episode moved you, challenged you, or made you think a little bit differently, please follow, subscribe, and leave us a review on your favorite podcast platform. And as always, let us keep asking the question, what about rural health? Until next time, I am still your host, Chinasa Imo. Bye for now.